This conference will now be recorded.
Hi, everybody. This is Len Sierra for the AnCan High Risk Recurrent Advanced Prostate Cancer video chat for Monday, November 20. And as we always do, we'll start out acknowledging our sponsors and thanking them: Bayer, Foundation Medicine, Pfizer, Janssen, Myriad Genetics, Myovant, Telix, and Blue Earth Diagnostics. And Rick, you'll let me know if I missed anybody.
Oh, I wasn't paying attention.
Oh,
I think
well,
you're good.
I think we probably got them all. All right, we're going to start with Joel Blanchett. Go ahead, Joel.
Yes, thank you. I saw Dr. E in as a televisit on the 8th of November. And as you may have recall, she said she would never give me Provenge or radium-223. And she told me this time that she thought the Axeman PET scan was useless. So that's another treatment she doesn't like. She wants me back in Houston in March. I'm currently taking SBRT to my T6 and T9, and I've had three treatments out of 5 so far. I'll be done by next Monday. In Houston, when I was there in August, seeing Dr. E, she had given me a pelvic, chest, and abdomen MRI, and which found no prostate cancer. And then she gave me a PSMA PET gallium 68 scan, found no prostate cancer, as you may recall. But she did tell my radiation oncologist to radiate L4, L5, T6, and T9. So I came to see my radiation oncologist a couple of months ago, and he gave me 2 other MRIs, a lumbar spine MRI and a thoracic spine MRI. And so I asked him when I met with him a couple of days ago, I says, well, why is Dr. East MRIs not finding cancer and yours is? And all four spots were positive on his MRI. He says that's because they're read, my MRIs are read by different radiologists, a different type of radiologist, which I didn't know there were different types, but they are, I guess. And he says, your pictures that we get to give you SBRT are taken in 1 millimeter slices. The scan that Dr. E gave you came in 5 millimeter slices. So if there's a tumor that's hiding in between, it doesn't catch it. Something to that effect. I may not be exactly correct here in my explanation, but that's what I got out of it. So I says, well, in that case, if you found 4 spots with dormant cancer, he says, yeah, he says, the PSMA PETs won't find dormant cancer. They only find active cancer. So I didn't know that fact either, and that was interesting. And he says, I said, well, then I said, the question is, why don't you do your type of MRI, my entire body, then you'll know where the cancer is. He says, well, that would be a little too much. He says, it'll take too much time on the table. He says, your main problems are in the spine. We've got to get rid of those. If you have a cancer in the ribs, not a big deal. That doesn't affect your overall health as much. So that was the answer to that. I'm getting a 5 SBRT to my thoracic spine currently, and in December he's going to give me another 5 treatments of SBRT to my lumbar spine. I have 2 questions. First of all, where is Dr. E? Because he was trying to get Dr. E. Dr. E wanted him to call her. He tried several times. They played phone tag, and he finally found her on Friday, and she says she was lecturing internationally. So that's where she is, but I don't know when she's coming back to Texas. I would be interested because I find out if I send her messages and she's out of the country, she doesn't get them and doesn't respond to them. So she only responds to them if she's in Texas most of the time. So, so if anybody knows where Dr. is, please let me know. The other thing is, and this may not be appropriate, but Rick can stop me if the question is improper. I have fallen 6 times since I've had my cancer treatments in the last 4 years. And I know that darolutamide and Orgovyx can cause some falls, predisposes you to some falls. Not a big deal, but it's a problem. I have fallen 6 times. I even fell on my back early November in Florida. And it hurt my thoracic spines. I was afraid that I couldn't take the radiation, but we did take an X-ray. My rheumatologist took an X-ray, and everything was fine, or still in alignment, nothing broken, and so on. So I lucked out there. So do you guys at your age and your stage of prostate cancer, have any of you fallen? So that I'll stop talking and you can answer the questions if you can.
All right, let's open it up to the floor. Anybody had any falls in the past year?
I haven't fallen, but I feel on the verge of falling. You know what I mean? I've never felt so vulnerable to a fall in my life. I was hiking in Colorado and I felt very unstable. When I go walking, I go for my walks. I feel, my legs feel very, very weak, like they've never felt before. And I have more arthritis than I've ever had before. I feel more pain. I feel just, I don't have a cane or anything, but probably it wouldn't be a bad idea to use something, if not a cane, maybe poles to walk with. But I walk, but I feel just like I've never felt this weak in my life, and I've run many marathons, so it's the medication. I know it's the medication.
Yeah.
So
The unfortunate thing is darolutamide, although it can result in falls, probably does so less than the other two choices of apalutamide or enzalutamide. So it isn't as if you can switch to another receptor blocker and expect fewer falls. So you think your falls are basically due to weakness from being on hormonal therapy, right, Jack?
yeah,
Yeah. And it is Joel, are you
I haven't fallen, Len, but I
right?
feel,
Yeah,
yeah,
I'm sorry.
but
Right,
I could fall easily. I feel because I'm weak in my legs,
right,
and my arms. Just a general weakness I've never had from this Orgovyx and darolutamide.
right. And Joel, do you think your falls are from weakness or just in a loss of sense of balance? We can't hear you, Joel.
Well, there's a couple things. One thing that can you hear me?
Yeah, we can. There's a
Hello?
delay.
Can you hear me?
Yes.
Okay. All right. So uh, I'm trying to I'm trying to start picking up a pattern where when I went to Florida, it was my first day there. It was early in the morning, like 5:30 in the morning. I was out on the sidewalk walking the dog, and I felt that I wanted to fall forward all the time. The last time I felt my way was when I was in Houston in August, when I went to see Dr. E. And when I got up, I felt like I was going to fall forward. I ended up falling backwards in the bathtub after I was trying to shave. So I got to be careful because it's I know when it's likely going to happen. I didn't pay attention to it. I just try to steady myself and keep on going, but I shouldn't be doing that. Best I can tell, it's after a lot of stress, after an airplane flight. It might be dehydration, could be a combination of things. Um, my first couple of falls were also in Florida, but that was just a misstep when carrying a load of laundry downstairs and falling in a pool of water that I didn't see coming, that type of thing. That was more of a stupid thing than a drug thing, I believe. But I am um, when my rheumatologist heard that, he says, "Oh, you must have prostate cancer on your brain, but you got to find out what the cause is." So that's why I'm bringing it up tonight. My radiation oncologist says it's very unlikely. It's not 0%, but very few people have cancer on the brain. So
Oh, so let me address a couple of things here. I've fallen more times than I care to count, largely because I have awful balance, or on 2 feet. But on my 2 feet, I have just horrendous balance, and very often I find myself losing my balance. I mean, it happened to me last night, but I'm close to something and I can stop myself. My balance has gotten a lot worse since I did hormone therapy, and it does affect some people that way. My balance was never great. So, I know that other people on hormone therapy have balance issues. Um, I don't put it down to strength. To some extent, I do put it down to age because as people get older, they lose their balance. Um, but I'm not sure beyond the hormone therapy that it's a prostate cancer specific issue. So that's my comment on that. Second thing I wanted to comment on was I wanted to clarify exactly what it was you said, uh, that your radiation oncologist said in comparing scans. Were you talking about CT scans or were you talking about PSMA scans?
neither. I was talking about strictly MRIs.
Oh, strictly MRIs. Okay. Okay. So, and then the third thing I wanted to mention was that your doc said that PSMA scans don't show dead tissue. This is directed at Len and any other Brains Trust people here. I don't think we have too many, but we looked at that last year, Len. Do you remember? And as to see whether PSMA was expressed in cells that were dying. And I can't remember whether we agreed with that or we didn't agree with that. Can you remember?
I think that I think it was PSMA that, or it could have been PSA that was still being um, lost into the circulation from the dying cell. Is
I
that what you're getting
remember
at?
Not
because I definitely remember Herb, God rest his soul, researching that.
Yeah.
We'd have to go back. We'd have to go back and look as to whether. Well, I guess I'll try and make a note, or maybe Len, you can. We can look and see about PSMA being expressed in cells that are dying. But what your radiation oncologist is saying is that um, if so, if if the cancer is dead or dying, it doesn't express PSMA. Am I right in saying that?
No, he's not saying that. He's saying that if you have dormant cancer because it's being arrested by Orgovyx and darolutamide, it's not dead yet. It's just dormant. It's asleep. That the PSMA won't catch it.
Oh, that's
In
different.
other words, if it's dormant and asleep, it doesn't express PSMA.
Correct.
Okay, I'd love if you could be kind enough to get a reference for that. I think we'd like Len, wouldn't we like to follow up on that?
Absolutely.
If we
Yeah.
could get a reference as to where um, what makes I mean, and he may be 100% right. We're not saying he's not right. It's just that I don't think have you heard that before, Len, that the prostate cancer cells that are not active don't express PSMA?
I can't remember, Rick, to be honest.
Okay.
Yeah, Larry. And then after Larry, I think Gary had his hand up. Let me see, who was that?
just wanted to get back to this balance issue and fear of falling. I had a lot of balance problems following chemotherapy and neuropathy that hasn't completely gone away. But I found that a series of exercises that I do has really, really been helpful for the last year and a half. I feel much more secure. Um, One thing, of course, I suggest, like you said, is Nordic walking poles. To use poles, you could use a cane, but I use a Nordic walking pole. The other thing is you can get like what is one of these pads that are sponge pads, and there's a whole series of exercises you can do for the foot and ankle, um, where you're one part of the foot is off and you're exercising the different areas of the foot and it strengthens the ankle. And following that, I think that squats, lunges, and other strengthening exercises may help, in addition to the idea that you're hiking, which is kind of hiking specific. It's a lot of muscles involved. But if you really work on squats and lunges, forward lunges and backward lunges, and foot and ankle exercises, I found that my balance, I feel much more secure than I did a year and a half, 2 years ago.
Okay, thank you for
That's
sharing
that's
that.
it.
Let me throw one more thing in, and you're absolutely right. If I had better knees, I'd do that. My knees are pretty shot from 50 years of skiing. But I think the one thing that helps me is when I remind myself to compress my core. In other words, my abdomen. In other words,
Right.
as if you were doing sit-ups. When I'm walking, if I could remember to, squeeze like and make your muscles
Yeah.
in your stomach bulge, I feel more rooted into the ground and more stabilized. But if I
Yeah. And
forget
I
and
was also
if I'm not thinking about that, then I can feel more vulnerable.
I would
So if I
also
could remember
mention
that,
planks.
yeah,
I
yeah,
would add planks for core
yes, yes,
stability
planks, sit-ups, all
and
that. Yeah,
things they call the dead bug or pointer dogs, but specifically planks on your elbows and your feet, where you have to
absolutely.
tighten your core in order to remain up. It strengthens. In the
Yeah,
beginning, I was getting soreness in my abs, and now I don't get that anymore. I'm working on
that's
extending
good.
those.
That's
All of
good.
those combination really have made my balance
Yeah,
really no fear of falling in the last year. And
that's great.
2, 3 years ago, I really had fear of falling all the time.
That's reassuring. Thank you.
Okay, Gary P., go ahead.
Uh, I have a story much like Rick's. I've had balance issues that were exacerbated by hormone therapy, and I have fallen a number of times, including in the last year. Um, Most of them outside, where I catch something and I'm down on the ground right away. Um, so I certainly have experienced that, Joel. Um, I also had a question. What did you say Dr. E had said about Provenge and that radium 223?
Yeah, it goes back to Nick Vogelzang before he died, said that Pluvicto was replacing Provenge and radium 223. And the doctor asked Dr. E about that, and she says, I agree with him. And then this time I asked her about what about instead of the FDG comparison to the PSMA PET in March when you're going to see me again, how about an Axiom PET scan? She says, no, I won't give that to you. It's useless. So those were her words. And so she doesn't believe in those three scans anyway, those three treatments.
So I missed it again. She doesn't believe in Provenge and radium 223.
Correct. At least not
Okay.
for me. Maybe for some other patients she would, but she didn't seem to be. She seemed to be negative on the whole thing.
Didn't you say you got a gallium scan, Joel?
Yes, I did.
So did she refer that one, or was that a different doctor?
No, she's the one who ordered the gallium scan for me because she gives everybody the gallium 68 scan. Before that, I had four or five DCFPYL scans. Also, I attributed some of my falling to my being top heavy. Dr. E also put me in Monjaro. I've now lost 21 pounds in 2 months. I hope to lose 50 pounds. As all of you know by hearing the news, Monjaro is now being called Zepbound, Zepbound. The FDA just approved that last week, I believe, or the week before, because the Monjaro is really a diabetic drug, but it was being used for weight loss. So somebody repackaged it. It's the same drug, I believe, chemically, but now there's a new name to it. And so it comes in 2.5, 5, and 7.5, I think.
So I just want to clarify on Axumin because it's important. Um, it may well be that Dr. E is not saying Axumin is not a good scan. She's saying it's not a good scan for Joel because Joel gets a response and expresses PSMA. But if you express PSMA, there's no question that the PSMA scans, whichever ones they are, whether it's gallium or the Pylarify or the forget the other names, they're the better scan. But if you don't express PSMA, there's definitely a role for Axumin. So, we shouldn't be discounting until we know whether or not, as an individual, we express PSMA.
Agreed.
Yeah.
And there's probably around 15 to 20% of men who don't express PSMA.
By the way, guys, I'm sure you'll have no problem finding YouTube videos of how to improve your balance with different types of exercises.
I got one more thing on falling in balance that I throw in that nobody did. I'm of course a big believer in balance exercises, leg strength, core strength, flexibility, all those things, as you know. But something that the old folks used to use that has lost popularity and some people are embarrassed to use it can be very helpful is a walking stick. If you're out walking and you're falling down outside, you might want to try carrying a stick with you, even if you think you don't need it, because a stick can really save you sometimes when you go down. Now, me, I'm not old enough yet, but you old guys, you might want to try that stick.
You young whippersnapper.
That's
I'll be
right. Hey,
ready for
Jimmy,
one by tomorrow.
Jimmy, you're going a bit the right way about getting kicked out of this group tonight, you know.
I'm right behind you.
Another good idea, guys, is well, this is true of all elderly people, not Jimmy, since he's not elderly, but they tend to shuffle rather than lift their feet when they walk. And of course, if you don't lift your feet, it's much more easily to trip, and lose your balance that way.
That is a great point. And when I get tired, or I see people do it all the time, you misjudge how high a step is. You're stepping on a curb, you're stepping on a bench, something like that, and you're tired. You come up a little bit short, just like an athlete who thinks he can make it safely into second base or dunk the basketball and comes up short. If you're not mindful of the fact that you're losing a little bit, you'll take the same gait, the same step, the same jump, the same move that you made before, and you don't quite get there. So sometimes you think about that.
Yeah, good point. I've experienced that sometimes climbing stairs. I don't quite get high enough to clear the step. That could be very dangerous.
Your
Fortunately, I
mind
haven't.
tells you that the step is one place, and your body is informing you that it's somewhere else.
Yeah. All right. I think we did a good job with that. Can we move on, Joel? Okay with you?
Thank you much. Unless somebody knows where Dr. E is, if she's still traveling or
Oh,
not.
right. We'll put out an APB for Dr. E. Les Shelderup, you're next.
Thought I hit it. Okay. Trying to get oriented here. For Gleason 10 patient, the treatments I've been on for the last 10 years worked quite well until the last few months, which is not so good. Darolutamide did a good job bringing the PSA down from 7.3 to 0.8 in 25 days, then adding chemo down to 0.35, but halfway through the chemo, it started back up again. More recently, Pluvicto brought it down a little bit at first, but now does not look too good. The PSMA scan a few days ago showed a few new lesions and a few old ones a bit larger. My usual doctor at the Mayo Clinic, Rochester, Minnesota, Dr. Kwan, was on vacation, but I was finally able to get an hour chat with Dr. Oliver Sarter. I was scheduled for my third Pluvicto round in 2 hours, which we discussed canceling, but we finally decided to follow through. And but he said that we did need something else. He mentioned either a different chemo treatment, cabazitaxel, which I know has been mentioned here several times, or actinium 225, which was a treatment that Jim Barnes had recommended to me a couple of weeks ago. Dr. Sarter seemed to favor the actinium. He said that he was working on doing that treatment at the Mayo Clinic, but would not be ready for it for another 5 months, and I could not wait that long. He mentioned 3 places: California, St. Louis, or Council Bluffs. I asked 2 in Council Bluffs, and he said Dr. Luke Nordquist. I said that I had spent 2 hours with Dr. Nordquist about 4 years ago, and he said, would you mind if I talked to Dr. Nordquist on your behalf? And I said no, so he tried calling him right on the spot. He couldn't get a hold of him at that time, but 2 days later, my wife got a call from Dr. Nordquist's office asking some questions and stating that they were setting up a conference in December for me to come see if I qualified for the treatment. And that's about it. At this point, I don't know much of anything about actinium, and I'm trying to learn something, but that's the status at this point. I don't really have any questions, just that's the current situation.
Les, I have a question for you.
Okay.
The decision between the second and third lutetium, why did they say go ahead? Was there some concern about your blood work, or?
Well, are you talking about the Pluvicto?
Yeah.
Okay. Well, the PSA was rising. From the PET scan, the lesions continued to increase in quantity and or size. So it didn't seem to be working. That everyone that observed it said that it's just not doing the trick. So they needed something else.
So it sounded like, though, that they recommended, that Sartor recommended you go ahead with the third treatment. Or maybe I misunderstood.
Well, yeah, it was kind of left up in the air. He kind of left it up to me, but in discussing it, he said, well, he mentioned the pros and cons of proceeding. The thought was it wouldn't really hurt anything to proceed with it. There was only a slight chance, he said, of it doing any good, but he didn't think it would hurt anything. The only negative, he said, it'll set you back, that you won't be able to do anything for 6 weeks. But the thought was, well, we won't be able to do anything for 6 weeks anyway, because it would take about that long to get anything else organized. So The thought was, well, you might as well, as long as you're here and they got it all scheduled, go ahead and do it. And there's a slight chance of it doing some good. Even
Thank you.
though it wasn't, doing the job that they had hoped, it might have been helping some. I think that was the theory.
So the discussion I think I would have had with Dr. Sartor was that we know many men where we haven't seen the lutetium kick in until as late as the fourth one, I think even the fifth session, and then it did. And so what I'm interested in hearing is why they were so convinced after two that it wasn't working. I mean, yes, your PSA was going up, and yes, there were a couple of extra lesions. Had any of the lesions on the PSMA scan reduced?
They didn't mention any, no. They said some had not increased, but some had, and then there were some new ones.
Okay.
Well, I felt that Dr. Sartor was very familiar with the Pluvicto treatment, so I figured he would
Yep.
be the one to ask.
No, I mean you're right, and he is. I would have been curious to hear
Yeah,
his reasoning. There may have been something that he saw that said this ain't gonna work,
yeah.
and I'd be really interested to know what that was. I mean, it could have been the combination of new lesions and the PSA rising. The PSA rose from where to where?
The last one was 5.7. I think the one before was 4.
Okay.
Les, was there any problem transitioning from Quan to Sartor?
I didn't transition.
Are you still seeing both?
As far as I know, it's just that the last, well, when I was supposed to see him in October, and for some reason he wasn't there. And then the next they said, "Oh, you'll see him in November." Well, he was on vacation in November, so I don't know what the deal was. Uh, I did inquire of the uh, person I talked to, a physician's assistant, and she was kind of blew it off, I guess. I didn't really learn anything. But the
Uh,
intent was to continue with Dr. Kwan. In fact, in the message that I read as his report, that he's going to consult with Dr. Kwan when he returns to see if he agrees with all this, so forth. I was
So
concerned about being conflict because I know Dr. Kwan is a little bit sensitive about getting other doctors involved, but nothing was said. I tried to tactfully inquire, but there was no indicator that there was any conflict there.
okay. You'd asked about actinium. Len, you want to take a shot at explaining the difference?
yeah, so lutetium or Pluvicto is a beta emitter, which is far less potent at killing cancer cells than an alpha emitter like actinium. The other difference is that actinium only travels a very short distance. So there's less likely to be collateral damage of healthy cells around the cancer cells. So Pluvicto is less potent in its killing power, but it has a wider outreach. It travels further through the tissues. So, I mean, that could be good sometimes, if it'll hit surrounding cancer cells that the actinium might not hit. Um, but it could also, if there are no other surrounding cancer cells with the Pluvicto, then that extra distance that it's traveling will be harming healthy cells.
Okay, so the actinium uses the alpha particles?
Alpha emitter, they call it an alpha
Emitter, yeah,
emitter, yeah.
emitter, yeah, right,
And the lutetium is a beta emitter.
right, okay.
Um, Radium-223 is also an alpha emitter like the actinium, although it's not attached to PSMA. It's a whole different mechanism of targeting the cancer cells in the bone, but those two are both alpha emitters. Jeff Markey, you had a question, and then Al Latimer after
Well,
him.
I was just going to mention the actinium has major effects on the salivary glands.
Yeah.
At least it's had, and gives you just severe dry mouth. Supposedly, they've been doing it in Germany for a few years, and it's supposed to be much more effective. I can go on with my question if you want.
Let me just comment on that. So they've actually experimented using some type of small molecule ligand, whether that's with the lutetium or not, I'm not sure, before giving you the actinium, so that it sort of masks, blankets the effect of the actinium. I don't know a lot about that. I heard that maybe a year ago. Len, do you know any more about that?
Yeah, I just heard that they were researching how to possibly block the effects of these PSMA therapies from hitting the salivary glands, but I don't know where they are uh, with that research.
Hey, Lynn, do you happen to, if you happen to run across any listing or showing of some of this information, if you could email it? I have been trying to search for stuff, but I don't seem to be able to come across the type of thing that I'm looking for.
So, Les, just
Yeah,
just Google, and you can do it was during the meeting and tell us, but just Google alpha emitters versus beta emitters,
okay,
PSMA. There's
okay,
loads of information. We've had, I don't think we are doing a webinar with Dr. Sartor in January. I'm sure he'll address it, but I mean, I've heard loads of webinars where they've addressed and explained alpha emitters versus beta emitters. I think the last one that they did on Prostate Cancer Foundation, I forget who did that. They talked about it there, that there have been any number. So there should be no shortage. It's just a question of Googling the right term. And I think if you try PSMA alpha emitter versus PSMA beta emitter, you'll find a slew of information.
okay. How about YouTube with the
You,
same
you, you,
question?
you, you need to Google beta
Okay,
emitter
yeah,
versus alpha emitter, and then if you Google it, it'll come up on wherever it is, on YouTube or anywhere else.
all
If
right.
you don't find it, come back to us. But there's a lot of information out there.
Okay, my concern has been, and I've run into that before, that I get information that's obsolete. I know I've run into that before on something where I talked to Len about it, and he said, "Oh yeah, well that's the way it was, but they don't believe that anymore." Uh, I wanted to know. I want to make sure I'm getting up to date information.
I'll help
Thank
you
you.
out, Les. Don't worry.
Yeah, thank
Al
you.
Latimer, you wanted to say something?
Yes, I was going to make the point about the actinium and the side effects of the salivary glands also. But beyond that, Les, when is your next PSA test? Because to Rick's point, you may not be at the end of the Pluvicto yet. I mean, if your PSA goes down again the next time, um, maybe you haven't reached the end of the Pluvicto either. Um, especially if it hasn't been my case, but especially since many people start seeing benefits after several treatments. Have you had many side effects so far?
It's kind of difficult to tell because I've gone so quickly from one thing to another to chemo, and it's almost overlap, so it's hard to tell the difference. But the only time I noticed with the Pluvicto, the first two treatments weren't that bad. I didn't notice much difference, but this last one hit me a little harder. Nausea. I end up barfing an hour before my final test for after treatment test. So this last one has hit me harder.
But
You're
guys,
getting
we've
dry mouth?
really got to move on.
Yeah.
We've got a lot of guys to go. We've only gotten through 2 in the first hour. So, Steve Nordstrom, I think you wanted time.
Yeah, I'll just be kind of brief. I just wanted to let you guys know that after 2 years of Zytiga and Lupron, my doctor has suggested I take a holiday. So my PSA has been undetectable. So now we're going to find out if the SBRT worked on the one spot I had. So I'm kind of happy about this. But my real question had to do with weaning off prednisone, and I know you've talked about it before, but can anybody give me a quick synopsis on I think 2 or 3 weeks is probably the best way to do it,
More than that.
and just cutting it in half, getting down to 1 milligram maybe.
If
Jim
it were me,
Marshall,
there are guys who are going to answer for sure who have done it. I can only tell you what we've observed, and to me, 2 or 3 weeks. How long have you been on the prednisone? 2 years, did you say,
Yeah,
Steve?
2 years. Yes.
To me, 2 to 3 weeks sounds very short. I mean, we got something going on with Peter Kafka right now. He's not on tonight, and I still
Oh.
think he came off of his prednisone too quickly. So, have you talked to Dr. Shmulewitz about this?
Well, I see him December 7th, so I'll get the final details on it. And I'm also going to see an endocrinologist while I'm at University of Chicago
Sure.
and kind of run through it with her. And
Okay, but I would say a couple of things. First of all, have you started the taper yet?
no, because we're going to start when I see him on December 7th. That was sort of the date.
Oh,
As long
so
as all my blood work looks good, which it should. Been
okay.
looking good.
So get a really detailed program from him, and if it is only 2 to 3 weeks, if it were me, I would challenge him and say, is that
Okay.
really long enough? Because I've seen some really nasty things. I mean, I think some guys can get off it pretty quickly. It doesn't bother them. But those that do bother them, it can be a huge 90-day to 180-day problem, and massive weight loss, and goodness knows what, and we don't know yet. And there are guys. Jim Marshall has his hand up. I know that he's tapered off, and I'm sure there are other guys. Len, is it okay if we go to Jim Marshall? You're muted, Len.
You're muted, Len.
yeah,
How
I
about
said
give
I
me a
already
thumbs up?
called on Jim Marshall. Go ahead, Jim.
Yes. Let's see. First of all, anyway, how much um, were you actually taking? 5 or 10?
5.
5. Okay. The thing I did was, let's see, I dropped it to 2.5 for 14 days. I then went 2.5 then let's see, every other day for 14 days. And I did the 2.5, I believe, every third day for 14 days. And I was on it for 5 years.
Right.
And I seem to be okay.
Good. Well, that helps a lot. That's a great way to do it. So I appreciate that. That's really all I had. So
All right. Well, when you talk to the endocrinologist, Steve, come back and tell us what they had to say.
I will. Because Shmulewitz a lot of times will say, well, 5 milligrams isn't that much, but I do know after listening to you guys, it's a big deal if it goes wrong. So appreciate it.
Okay. Jefferson.
Hold on. I think Al Latimer had his hand up too
Oh,
with respect to that.
go ahead, Al.
No, that's okay. I was just going to say it took me like 3 months to wean off of it. I just had a terrible time with it. But I
Okay,
did a
no,
real,
that's really important. I really want Steve
Yeah.
to hear that because some guys can get away with 3 weeks, but some guys, as you hear, Steve, so we just don't know. But what we do know is that if you go too quickly, you're going to regret it big time.
So what are the main problems if you're having a problem? Just you feel like crap and you lose weight? Is that what it is?
um, yes, you feel like crap. You feel like the couple days after a chemo treatment, when you hit that low, you just stay in that low. And
Okay.
at least that was my experience. Well, so the doctor just said, well, it's taper slower, and I did, and eventually I was able to stop it. I was on 5 milligrams also, but it was only, I guess it was about a year and a half altogether that I was on it.
Okay.
But I
Appreciate
did
it.
have a hard time with it.
Thank you, Al.
All right, Jefferson, you're up.
Can you hear me?
Yep.
Okay. I've been going through this since 2019, and each treatment was for about a year or less, and then I'd go to another one and another one, and I got up to the Pluvicto, and then I changed doctors because my doctor of 4 years went to a different specialty, and the doctor that I got said, "Oh, this Pluvicto ain't doing nothing. It ain't doing this." He didn't say specifically what it showed it didn't do. He just said it's not doing anything. So he put me on this cabitaxel with prednisone. And in the meantime, I had what I call my cancer wanted to chew on my backbone. And it was chewing onto my backbone. And I had to have an operation for the T1, T5 posterior spinal fusion and T4, T2, T4 laminectomy. And the people who were taking care of me did not realize keeping me laying down in a bed for 8 weeks, I lost at least 50% of my muscle tone and ability because they had me laying on my back constantly. Once I got sat up, walked around, and then sat in a chair for 3 hours, and that was my physical therapy. And I thought that was atrocious. And now I am going through wonderful physical therapy to try to get those muscles back. I had them before I went in to the hospital. And I'm just frustrated. And my doctor says, well, you only got 6 months to a year. And that's it.
Wow.
And it's
Right.
frustrating.
I think you need a
There's
new doctor, someone with a little
I
more
just got
compassion.
the new doctor and he has so many different credentials after his name. He's a professor of medicine and public health, associate chief solid tumor oncology program, James Wilmot Cancer Institute Division of Hematology and Oncology, Department of Medicine. And he's a nice guy. But I got
Well,
spoiled by my first
well,
oncologist.
look, Jefferson, you know the score here.
Yeah,
You were seeing a doctor that we didn't like very much. We spent a long time trying to convince you to move to Dr. Vanderheisen, is good and
Vanderheisen is in charge of the
okay.
group.
Let me finish, and
I'm
then
sorry.
by all means respond. Who's very good, and you've got other guys in this group who saw Dr. Vanderheisen, and they all liked him, and then he goes and leaves. So now now they've switched you to somebody else. It's not the credentials; it's how much they know about treating prostate cancer. And Dr. Vanderheisen knew how to treat prostate cancer. You may be with a doc. I don't know what his background is and how familiar he is with prostate cancer. He may be a fantastic breast cancer doc or lung cancer doc, but he just does prostate cancer on the side. So the first question is, what experience does this fella have with prostate cancer? And if he doesn't have the experience, it may be that there isn't anybody. I mean, Tony Fig, who are you now seeing? Who are you seeing at Wilmot, and do you like that doc?
I haven't met him yet. My first appointment is December 4th, but he has pretty good credentials, but I can't comment on him right now.
What and is maybe it's the same guy that Jefferson's seeing. What's the name of your doc, Jefferson?
Chunky Fung,
I-
Fung.
Is that the guy that you're supposed to see, Tony?
No, I don't recall his name right now.
Okay,
I'll try to find it and put it in the
could you
chat.
do it? Could you look it up and send it in the chat window to,
Yes.
because I think, and have you done any research as to who the best alternative is now that Dr. Van Zerheisen has left Wilmot?
Yes, this doctor was highly recommended by a couple of other resources that I have, and I sent the credentials to you, and you thought he was pretty good. He worked at,
Oh, right. Yes.
yep,
Thank you.
yeah, he worked at Memorial Sloan Kettering, had a fellowship
Right.
there, and also Brigham Young's.
Right. Thank you for reminding. I'll also look, Jefferson. I'll see if I can find the name.
I appreciate it. Because my previous doctor at least gave me the simplest thing. When the diagnosis was made, that was diagnosis. Everything was in ink. And a prognosis was in pencil. Because there are many possibilities that I went through in the past 4 years with this doctor. And I can't complain.
All right. Well, let us look and see if we can find out the name. I do recall Tony did send me his name, and I got to see if I'm sure I can find it, and we'll try watch the chat window. Keep an eye on the chat window, and we'll try and figure out who it is. But any doctor who turns around and says to you, "Well, you just got 6 months to live," he ain't my kind of doctor, however good he is. So
No, it gives you no
that's
hope.
go ahead.
I just said he gives you no hope.
Oh, he gives you no hope. You're right. You're absolutely right. Brendan, I got it. Oh, look at that. I got it. The name of the doc that you want, I'm gonna put his name, and I'm gonna copy it. I'm gonna put it in the chat window right now and copy a link. That's right.
Now
His
I got
name is Brendan Guercio, 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 Brendan Guercio, and I put a link to him, and I'm sending it out. I'll send it out to everybody, and there it'll
now
save Tony Fig looking around.
now all I got to do is figure out how to get this window open. The window, I guess. Oh, this would help call and must. Oh,
So it's the window of the two little squares in the top right hand corner. Just click on those two little squares and it'll open a window for you. Got
session
it?
info. I got a session info.
Do you see where there's a little man and it says 36 next to it?
Oh, a little. I see 37, but it's okay.
Okay, well, maybe it's 37. Do you see next to
I,
that? There's
I, I
two.
yep.
You got
There's
it?
two. Should I click on the chat
Click,
pictures?
click, click on the chat and you'll see I put
Okay,
the
Brendan,
message
I got you.
before you. Okay, and if you click on that link, it's live, it'll open in your browser and you can look at it later. Just click on that and it'll open up for you and you can check it later. Okay, how's that? Service with a smile.
Well, that's great. Thank you.
All right, Jefferson, we're going to move on to Mark Valens. Go ahead, Mark.
Well, it's been quite a interesting last couple of weeks. You know, at the beginning of the month, I found out that my cancer is recurring, and I got new mets in my pelvis, and getting set up to do radiation for that. And then I I get blood work done every 3 months, and on a Friday afternoon, the numbers came back and shocked me. All my kidney numbers were just way out from where they should be. And it took me all weekend to get hold of my doctors. But once they saw the numbers, they sent me straight to the emergency room. Basically, I had acute kidney failure. Um,
Hmm.
and their theory is that I've been having trouble with peeing for years. And I've had surgery, I've done other things trying to pee better. Apparently, the urine backed up into my kidneys and shut them down. Um, and it was not on my radar to be watching my kidneys, but so I was in the hospital for 4 days and then back to the ER twice since. But they installed a couple of nephrostomy tubes into my back, one little tube into each kidney that then drains out into a bag. And I'm doing a lot better. My numbers are looking quite a bit better. But boy, until we got that figured out, I've never felt so weak or so. I thought my life force was draining out of me. Um, so, anyways, those tubes have to be removed sometime, but not yet. And um, we still got the metastasis in my pelvis, where we still got to radiate that and get to work on it. Um, and with this whole kidney thing, all of a sudden I had blood pressure problems, which I've never had in my whole life. So now I got to be watching my blood pressure. Um, and I'm still really weak. And you were talking about balance. I got to be really careful going up and down stairs because all of a sudden I'm starting to fall. Um, But so we found a good kidney doctor, and um, I, I'm talking to the radiation oncologist, and we're going to zap my pelvis. Um, so I'm doing all right, but it was a really scary couple of weeks.
Mark, I'm
And
curious, how often were you getting your blood checked before the numbers came up so bad that you were in kidney failure?
every 3 weeks.
Every 3 weeks, were you getting a metabolic panel?
Yes.
So
And
they
if you
have,
look at the history, all my kidney numbers are straight across the bottom forever until that very last test. They just shot through the ceiling, and they
wow.
said that's just because my kidneys shut down.
Huh. I don't know, Dr. Jack, does that sound a little peculiar? I mean, wouldn't you expect
Yeah,
the BUN and
yeah,
creat to
yeah.
go up
Well,
gradually?
yeah, he's describing, retrograde pyelonephritis, where his urine backs up and goes into his kidneys. Usually that would be heralded in by chills and fever and something, that would indicate that his kidneys were being affected. And you had no symptoms at all, and suddenly they told you were in renal failure?
Well, no,
Is that
the
correct?
10 days, leading up to this, I knew something was wrong. I was feeling weak. I was feeling tired. My brain was scrambled. Um, and we kept looking at other things. Like I say, I wasn't really looking at kidneys. It never even crossed my mind. But as you know, my regular blood test, when that came in, I took one look at that and I said something's drastically wrong here.
So
What happened
I,
with your neck?
I have a
Are you,
question for you. I have a question for you, Mark. Do we think that the resolution of this kidney failure might also resolve your urinary issues, or are they completely separate?
Well, it's resolved it because I've got 3 different bags draining me now. So, which actually is very convenient. I don't worry about peeing now, but the the tubes in my back are going to have to come out. They don't want to leave them in too long. Uh,
And
so,
how does the neck brace come into all of this?
good question. I was in the hospital for 4 days in a hospital bed, and my neck sort of had a little kink in it. But then when I went home and I woke up the next morning, I could not get up. I could not move my head. I moved just a little bit. The pain was incredibly sharp. And I had my wife kind of lift me up while I held my head, and went to the emergency room. And the emergency room doctor, who of course is not an oncologist, she thought that the cancer had gotten into my neck, especially since all my pain is on the left side, which is where the cancer tends to go if it's going to go into the neck. But I just saw my local oncologist today, she's not a genitourinarian, but she's pretty damn good, and we just can't believe it wouldn't have shown up on the scan.
That's right.
Um,
That's
but
right.
I'm going in tomorrow for an MRI, and that should rule out that it's the cancer in my neck. Um, and I don't, we can just call it a pinched nerve, but I've had back problems in my whole life. I've never had pain like that.
Sounds like Jefferson not moving him around and him being in a terrible shape after he'd been laid out. And, they don't come in, they don't move you around, they don't roll you over, this, that, and the other. And yeah, can see it.
all right,
Well, at
Mark,
least
we hope you feel better. Do you have any more questions or?
no. I hope in a week or two I'm going to have much better report for you.
I hope so too. All
Hey,
right.
and having all you guys backing me up really helps. Thank you.
Yeah.
All right. Uh, Jeff Markey, you wanted some time.
Yeah, I ran into a friend of mine who mentioned that he went from Lupron to Orgovix. And on Lupron, he was having really severe hot flashes. And in Orgovix, it's much better. Does anybody else run into that?
Julian, you raised your hand.
Yes, yes, I was having the really ferocious hot flashes with Lupron until I changed to Orgovix. It was amazing.
Oh, first I'm hearing this. Anyone else have been on both and had that experience? Okay.
Just another quick comment. On darolutamide, my PSA went from zero point 0.3 to zero point 0.1, then up to 0.2. And I had my one metastasis zapped a couple of weeks ago and back down to 0.1. They say it's not supposed to make a difference, but if you don't have a metastasis putting out PSA, why wouldn't it? That's about it.
You
Well, I
using the
mean,
same lab?
yeah.
What was that?
You're using the same lab?
Oh, yes.
Okay.
I'd say a couple of things. Your PSA has been fluctuating around zero point 0.3 and 0.01 for about 2 or 3 months now. So
Actually,
it's
then that's not true. It went to
okay.
one. It went to one when I went down to 3 Zytiga, and then
Yeah,
I was taken off Zytiga. The next test was zero point 0.3 when I went on to
yeah,
darolutamide, then 0.1, 0.2,
yeah.
zero point 0.1. So on darolutamide, on Zytiga, it had jumped around a little
All
bit,
right,
but I'm not.
call me a liar. Has your all I said was your PSA's been going between about zero point 0.3 and zero point 0.1 for the last 2 or 3 months. That's right, isn't it? I mean, there
Well,
may
it
be
was
reasons,
because
but
I
it has been
switched
jumping
drugs.
around.
It was because I changed drug regimens.
Well, we don't know. And that's the problem. You know, you in your mind think, oh, well, I did this, I did that. This is why it went up when it went down. First of all, these are not big movements. For people, for guys who have advanced prostate cancer, a switch of 1/10 is is not a big movement. And I know it's very hard for a lot of the engineers and technicians among us not to lose ourselves and bury ourselves in these switches, but they are small movements in the overall scheme of things. So it could be the drugs. It could be the fact that you had SBRT, which yes, if you knock out, you know what sometimes happens is it goes up before it goes down because the dying cells kick out more PSA for some people. But I would say that if you know, there's no difference for somebody like yourself. The difference between zero point 0.1 and zero point 0.3 is not huge, Jeff. I mean that's the way I would look at it. I would I mean I'm trying to get you guys to have a slightly bigger picture. And anybody can shout me down and say no, you're wrong, or but including you, Jeff. But that's I want you. You know we get so anxious about it's gone up 0.1, it's gone down, and we're trying. We know if we can lift this anxiety a little bit, that's probably going to have a bigger effect than anything.
All right. Alan Moskowitz, you are up, my friend.
Okay, thank you. So I have a question for the group. I'm in a situation where my PSA has just tweaked up a bit. I had surgery 10 years ago, I had radiation a few years back, and I was on hormone therapy last year with enzalutamide and Lupron, and ended treatment at roughly the end of last year. At that time, the PSA was undetectable, less than 0.006 or something like that. And the prognosis was simply that at some point my PSA would start its rise back up. Now, in my case, I was fortunate in that the cancer was never really super aggressive. I did have the Gleason 4+3, but my PSA doubling time wasn't bad. It was varied, but it was roughly, say, 15 months or 16 months. And so it was about 5 years or so, almost 6 years, from the time I ended radiation till the time I had the hormone therapy. And so the question for folks, based on their own data or their own reading, is should I expect that doubling time to at least start off um, following that same slow, let's say 15-month thereabouts doubling time? Or does the previous doubling time have no relationship to what I should expect going forward for the next few years? Any thoughts on that?
I don't know, Rick, you have anything to say on that?
He's
You
speechless.
know, no, I mean, it's impossible to answer. I mean, I think we have we know what the nature of our cancers. If we have recurrent and aggressive cancer, we tend to know how recurrent and how aggressive it is. Um, there's a guy whose cancer just came back after 3 years, and he's petrified, but his cancer doesn't move that quickly. And I have no idea if there is any empirical evidence to this at all. But my assumption is that the patterns that you've seen in the past, when the cancer comes back initially, are going to be similar to what you see at the time. And some of you guys can tell me if that's true or not because you've lived through it. I can say that as the cancer progresses and changes and does certain things, it may show more aggressive doubling time or different features. But I think that initially our history is probably quite reasonable. I mean, if we had slow doubling times, it's unusual to see somebody come back with very fast doubling times. But I mean, there are people in the group. We should, speak up empirically and tell Alan what you've seen in your own cases.
Well, I certainly had a very slow doubling time for many, many years. You know my story. 15 years I had a recurrence after 15 years after surgery. Then for 5 years, very slow, very slow, very slow. Everybody said indolent, slow, 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 and it was. And I never, all of a sudden, out of nowhere, my doubling time suddenly I'm up down to 5 months doubling time, and my PSA went from undetectable to quite detectable, and that's when I had a biopsy and it was diagnosed. So I don't know what to say in the future is going to happen, whether or not it's going to go back to being indolent, slow. Again, I would hope, but I don't think so, because the immune system, I doubt if it's going to get better as I get older. And if it doesn't get better as I get older, unless some miracle happens and I go into some kind of a Zen state of meditation where I get very calm and relaxed and suddenly I reverse it, I would imagine the odds of it coming back aggressively once again will happen at some point. I have to be prepared for that. I don't know. I don't know how to predict that. I'm not sure anybody can, as you said, Rick and Len. I don't know, but that's my experience.
Okay.
Are you doing any scans along with the monitoring of your PSA?
Did I do any scans for those 5 years?
Oh, not you, the person
Oh,
who.
me. Yeah,
Sorry.
I did. I've had a bunch of PSMA scans. In fact, I was in a clinical trial down at NIH when they were doing it, and they did see tiny little spots in my lungs, nowhere else. At the time, they didn't think it was cancer, but again, they were still refining the technique and the significance of these early lesions. Ultimately, they did find a few, um, and at that time, my PSA was up about roughly 5, and I decided it was time to start treatment. Although, frankly, my oncologist, both my oncologists at the time, said, "Oh, I could go to PSA 10 if need be, or maybe higher, as long as the doubling time was slow." Well, I could go higher, but I chose not to. And well, my oncologist thinks, probably I'll start off with the same slow doubling time. That's his best guess. Says ultimately doubling times will increase, but that may be a long time off. That was his thinking, but I had to sort of push him to get an answer. He didn't really want to say, or he felt he was maybe guessing more than speaking from hard data. That's why I brought it to the group, because I get some different points of view.
But have
Okay.
you had any scans recently?
Sorry, what was that?
Have you had any scans recently?
The most recent one was, well, late 2021. That was a PSMA scan, and the only other scan I had was an MRI that basically looked for that lesion, and no, not an MRI, CAT scan that looked for that same long lesion and could not detect it, which was consistent with my PSA dropping back to undetectable after just a few months of hormone therapy.
Yeah, it just seems to me that just doubling time alone, which you can't really predict very well, nor anyone else can that I know of, it might be just one of the things you should look at. You should possibly look at getting a scan uh, periodically, maybe once a year. This is a couple of years since your last scan, um, to get some relative balance in what you're looking at.
Well, it's a thought, but from what I know, PSMA won't show anything till you get up to maybe PSA, I don't know, 1 maybe, before you see something definitive.
Well,
So,
I mean, no, that's not exactly true. I mean, I
okay.
don't know. I mean, there's a lot of issues about what PSMA will show, and if you had cancer, and if you, I can't remember, did you have metastatic, clear metastatic cancer in the past when you were on the hormone therapy, Alan?
Only a few nodules in the lungs. That was it.
Okay, so in a case like yours, probably you are gonna have to let it get up. I mean, they talk on recurrence. On recurrence, they now say this is recurrence after surgery. They're now saying start looking as early as point 1. One thing we know is that we're doing a lot better at being able to read scans so that we can see cancer between point 0 and point 5. There was a paper that just came out. Um, I was reading it today, came out in April, that compared reading scans between 2015 with reading scans between 2015 and 19 or 20 between 2021 and 22, and we're seeing it better. Why are we seeing it better? Because people know how to read scans. Hello, we've been telling SNMMI that for the last year, but they don't want to believe us because we
Right.
know that experience badging is important, that the more experienced you are, the better you're going to be able to read scans. So some of it is when can you actually see it? When does it actually pick it up? I should say. What do you need? And the other is it may pick it up, but when does the reader actually see it? Because the reader may not have had an experienced enough eye to see it, and that's a big problem.
Okay,
So
well, I
so
was
I
going to say,
think that, but
go ahead,
I
Rick.
want to go to Len. I want to go to Len because Len, probably nobody has as much experience as you as going on holiday and then coming off holiday and going on holiday and coming off holiday. How has your Dublin time been pretty much consistent each time you've gone on and off?
Absolutely not. As a matter of fact, the first drug holiday I went on, that was the year I was diagnosed, 2014. My PSA started doubling like every 3 weeks. But then I went back on hormone therapy and I had radiation therapy. And post radiation therapy, my PSA doubling time was very slow, on the order of about 12 months. But, then eventually, like after I was just coming off 21 months of a drug holiday, the last couple of months it started going up at a slightly faster clip. So I think the short answer, which we've already heard to Alan's question, is it really isn't very predictable, the doubling time. Sometimes it'll be fast, sometimes it'll be slower, and then it'll get fast again. At least that's my experience.
So to further on sort of Rick's comments, so let's suppose that my PSA continued to rise. Why would I bother getting another PSMA scan before there was a reason to treat it? In other words, so I see it on a scan at PSA 1 or 2 or 3. If it's still a doubling time that's, not high, why bother getting the scan? Why not wait till I get closer to an actionable PSA?
It's really difficult to tell. I have a very low PSA. It's been anywhere from 0.08 up to now I'm at not 1.1, I'm at 0.16. I've got extensive cancer in my body. Doubling time doesn't make any difference anymore. It has to do more with where the cancer is and how aggressive the cancer is, not so much doubling time. So just a low PSA does not indicate by itself that you don't have much cancer in your body.
Okay. All right. Very good. Thank you.
One of the things my doctor always asks, Alan, is how do you feel? Do you have any pain? I think that's important in trying to uh, determine if something's going on or not. I'm talking about after recurrence. Of course, we all know that prostate cancer always starts off completely asymptomatic until it gets very advanced. So when we as advanced prostate cancer patients have recurrences, have increases in PSA, it's important to do a self-assessment. Like, how do I feel? Do I have pain anywhere? Do I feel more tired suddenly? Things that would make you suspicious that something's going on, and maybe you do need a scan.
Okay.
In your case, you were a Gleason 7, right?
Right. Yeah.
Not particularly aggressive. I wouldn't be too worried about scanning right now. I kind of agree with you. I would wait till, as long as you're feeling fine.
Oh yeah. Yeah, I'm fine. I certainly don't have any fatigue.
Yeah. And, wait for 0.2 and then insurance will cover it, a PSMA PET scan. All right. We do have Alan C. in New Jersey.
Yeah, I do have a question for the group. I just finished 6 months of Orgovix according to the plan from Dr. Geinesman, and basically my PSA has plateaued. The last two were 0.05, which is higher than what he was looking for. He's looking for non-detectable, and the testosterone has also seemed to plateau between 2 and 3. I did have a MRI last week. It shows that the one of the tumors on the left side is still visible. The tumor on the right side is no longer visible. The tumor on the left side is shrunken quite a bit. In the MRI before the Orgovix, the tumor was approximately 1.4 by zero point 0.9 centimeter. It's now zero point 0.5 by zero point 0.3 centimeter. The one on the right side was on the previous MRI 1 centimeter by zero point 0.6 centimeter. On this last MRI, it was not visible. My question for the group is any suggestions what to do next?
Rick, do you have a background, quick background
Let me
filler on
let me give
Alan? I
you
don't know his history.
his diagnosed with Gleason 4 plus 5 back in 2018. PSA was 6.5. There were two tumors within the prostate. No evidence of any metastasis at that time. Underwent 81 gray radiation with concurrent firmagon treatment for 8 months. The PSA went to non-detectable in November of 19, and then it started rising after that. When it was at a PSA approximately 1.0, we did a polarify scan. It showed that there was uptake pretty high on the left side, 20, 24, 25, nothing on the right side. That was back in 21, uh, late 21.
Alan, could you be a little more specific when you say left side, right side? What are we talking about?
The prostate itself, left side peripheral, right side midgland.
There was a recurrence in the prostate gland itself.
Yes, it appears to be the same tumors that were radiated.
Right.
So it looks
Yeah.
like they came back.
Let me jump in here. I mean, we had this same conversation, Alan, last month, because
Correct.
I'm looking at my notes here that
Right.
your PSA was less than zero point 0.5. And what we said is ask for scans, then make a decision based on the result that you may need a biopsy, is so that we can try and see what the nature of this recurring tumor is, because it's very unusual for it to recur in the gland after you've had 45 EBRT treatments. So get a biopsy, and maybe you need some more gland-directed therapy. Did you discuss that with Dr. Geinesman, and what did he say?
Yeah, the last discussion with him is to stop the Orgovyx because I had asked him. I mentioned that there was a study that shows it should have been longer than 6 months, but he seemed fixed on 6 months to take a holiday. And I seem to remember in the last meeting last week, you said you saw a recent study that was 18 months. Did you ever find that?
Yeah, I mean, there are studies out there that are longer studies. I sent them to a couple of people. I can't even remember who. But there are studies out there. The original study was 6 months. There have been studies this year that have said maybe it's good to do it as long as 2 years. But your situation is really different because all of those studies generally refer to people where there is recurrence that isn't in the gland. And so your situation is really different. And it may be that we don't know if treating you on a systemic basis is even impacting the gland. So I come back to what we said last week what we said last time in December, that talk about biopsying those tumors that they could see and getting them analyzed and try and see if there's something special going on.
Well, the last consult I had with him, he said, let's stop the Orgovyx and wait till the PSA comes up to 1. And then at that point, we may want to do another Polarify scan to see what's going on. I do have an upcoming consult with him. I requested one, so because that was before the MRI results. So he hasn't seen the MRI results as of yet.
Okay, can he see, or can you see clearly tumors in the gland?
According to I can't see, but according to the radiologist who read the MRI, he said there is
Right.
a shrunken tumor on the left side. It was originally 1.4 by 0.9 centimeter. It is now 0.5 by 0.3 centimeter. So in
Okay,
my
and
mind,
this was with an MRI?
correct. And in my mind, is it possible that the tumor is dying and it hasn't been, it's why it's shrunken, because the one on the right side, they can no longer see.
This is why I'm saying maybe you need to do a biopsy and see what they come up with and see what they see in there, and then based on what they see in there, you can design a treatment that will impact it.
Well, my
Anyway,
thinking is, yeah.
I'd like to bring other people into. I mean, this is pretty unusual. So, what do other people say, and how do they respond to Dr. Geinesman?
I find it strange that they took him off Orovix. It seems to me that might be what's keeping it in control. Taking off Orovix, if there's still cancer there, it just seems to me that you're uh, allowing the cancer to particularly to continue to grow. So, just seems strange to me. That's
Well, that appears to be his policy because his other patients, he's done the same thing.
Well, we know he's done the same thing like with Alan Babcock. I mean, Alan was only on for 6 months and Alan argued with him. And that's because there are doctors, and Dr. Geinesman is one of them, who feels he should do no harm and feels that 6 months is specific because that is what the study from about a year and a half ago said. I can't remember who I sent this longer one to. Alan, didn't I copy you on it?
I think you
This
might have. I'd have to go look for it, but I would tell you, I'll just give you one hint. You do not say to Dr. Gainesman, oh, my information came from AnCan. He really doesn't like to hear that. You can say, hey, I read this research piece. You can get away with that. And I forget I think Ben was the one who said, Alan, don't do that, because I told him that's what I did. So there's a piece of advice for you. But yeah,
I
that's
have not mentioned AnCan to him,
yeah,
but
6 months. And
I
I
did
said,
ask
no.
him, should we go longer until we hit the non-detectable, which
What
is,
he's going to say is no, I don't think so. But so yeah, I would have a piece of research in your pocket to say, listen, I read this, so I'm feeling uneasy with stopping. If I had to do it again, that's what I would have done.
have people heard that the last week Xtandi has gotten FDA approval for use in people that have non-metastatic prostate cancer?
not just has it gotten approved, it's gotten approved as a monotherapy.
Right, so I'm thinking maybe that would be my next course instead of Orgovyx, because I
Yeah,
did
but
have a
you're not
lot of
metastatic. See, that's the
non-metastatic,
problem. But you're not
non-metastatic.
metastatic. But there's no but
Well,
we
the
see it,
reason is
see it in your
Orgovyx,
gland.
right?
We
Orgovyx
still
has
see it.
caused a lot of side effects because my diabetes has spiked under Orgovyx.
Okay,
So I'm looking for maybe a different type of
try him,
treatment.
try him, Alan. Maybe you'll get it. Maybe he'll.
Now, there's the group think that another Polarify scan may be useless, especially if the tumor is indeed dying or died off. Because I'm
Well, that
thinking that'll
gets
be
back to the
another.
question. That gets back to the question that we raised earlier on: is that we're not exactly sure. We can't remember, and we got to research what whether dying cells express PSMA or not, which was something that Herb looked at. Like
Because
we
I
just
read,
can't remember the answer.
yeah, I read in the past that when the tumor cells die, they actually put out a lot of PSA, and that's why
We're
you get the
talking
PSA
about
bounce.
PSMA. PSMA.
Yes, yes. When
That's
the
different to PSA.
right. Well, I'm saying that um, you know, the PSA bounce that's known in some people after radiation. The theory is that the dying cells put out a lot of that, and
Yeah,
that's
but
what
that's
causes
not
this
your
problem.
question, Alan. Let's focus on your question. We know dying cells. That's something else we said earlier in this meeting tonight. What you're saying is, should I have a PSMA scan? Is it worth me having a PSMA scan?
Yes.
And the answer is, we know that you've got something going on inside the gland. If it's dying cells, we don't know if dying cells put out a lot of PSMA. That's why I just said, we're not sure because we don't know whether dying cells put out PSMA or they don't. If dying cells don't put out PSMA, it's not going to show up much.
Right. But that was just one of my questions to the congressman. But
Yeah.
Okay,
And
it's a good question for Gynasman.
because I would like to avoid the biopsy as much as possible if we can.
yeah.
Why is that?
Well, the first biopsy I had, it was massive trauma, severe bleeding. My prostate
Okay,
swelled
good
up for
reason.
2 or 3 months.
I mean, if you were to do it this time, you should do it. We would say we don't give medical advice, but we have enough on this one that it should be a transperineal biopsy anyway,
Correct.
which is likely to be a much safer biopsy. And which they do at at uh, at, at Fox Chase.
Right. Well, that
So
would
it
be
would.
my last alternative if we have to. But what about waiting to see if the PSA either stays the same or continues to drop? That would be the indication that perhaps the tumor is dying off.
I don't know your specific situation. I'm not super knowledgeable, but Gynasman was not willing to let me. That's what I asked him to do. I said before doing radiation, I said, "Well, let's see if the PSA goes up." And he said, "You've got an aggressive cancer. No, we have to be aggressive."
Really?
And
'Cause
Dr.
I
Wong
have
was
a
like,
Gleason 9, and he told me after I stopped the Orgovix, I asked him what would be the next step. He said we will wait till the PSA comes up to about 1, then do another PSA MA scan.
"Right."
So that
And
seems
you
to
had
be different than
radiation, and
what
I
he's
had a
telling you.
prostatectomy.
Okay, I had radiation.
Right. So that could be a difference there because he wanted that radiation, man. He was like, "No, you will have radiation." I don't feel like I had much of a choice.
Okay. But that's what he told me the last visit. I have an upcoming one, so I'm curious to see if he changes his tune based on the MRI results.
Yeah.
So
I
what
mean,
That's
is
all I
his
said.
recommendation at the moment, knowing that the
Pre
scan?
MRI, yeah, pre MRI. He says 0.05 is low enough according to him because I asked him. It's not non-detectable. He says low enough. We'll take a holiday, monitor it, and if it starts to creep up, he says that based on his experience with his other patients, pretty sure guaranteed 6 months to 12 months without a problem based on his other patients who were on Orgovyx. But he says if it does go up, when it gets to about 1.0, we would do another Polarify scan, or possibly MRI also to confirm the Polarify. That was prior to the MRI, so I don't know if the MRI results will change his recommendation because
And
it
the
does show.
MRI was a full body.
No. The MRI is just the prostate.
Oh, so if you had a PSMA PET scan,
since
I
your
did have one prior to the starting of the Orgovix back 6 months prior. I did have a PSMA scan, then I had an MRI to confirm that. So that was before I started Orgovix. Now, after I finished Orgovix, I just had the MRI scan. I haven't had a Clarify scan yet.
and so your PSA is 1.0.
No. PSA is the last two was 0.05.
Oh,
Last two results. So it may be too low. That's the other thing. It may be too low for a PSMA scan.
yeah, definitely.
Well, it's not going to be too low for a PSMA scan if you've got a tumor sitting there, and if the tumor's healthy. I mean, it's only too low when we're looking for cancer and we don't know where the tumor is. If we know we got a tumor, I mean, Alan, with respect, I feel like we're going around in circles here, man. I mean, we don't know. We're not docs, but you've got a very strange situation with a recurrent tumor in the gland. It's really unusual. And, whatever we suggest, and it's always, when you come on, it's the same. We suggest, and there's a reason why not. So we can only give you the same ideas that we've gone. If it were me, I'd go to Dr. Geinesman and I'd say, whether or not you like biopsies or you don't, I want to know more about this tumor that we can see that's in my gland. Let's get that information and then decide how to treat it. Otherwise, this is just we're going around in circles. We've got two other guys who need time tonight. And, I feel like we're no further along. I mean, do you feel that you've gotten anything out of this, Alan?
Well, I get some perspective from the other patients, which is good, helpful.
Okay, and their perspective is?
Well, the PSMA scan may show nothing. You're saying it may show something. So that may be an option to do that versus doing the biopsy.
Yeah, but it's not going to help us to treat it. We don't need a
Well,
PSMA
if it
scan
shows
here if we know that you've got a lesion. You got lesions in there.
right,
Take
but
a needle, stick it in there. Why are we doing a PSMA scan? There's lesions in there. Stick a needle in there and let's find out whether it's prostate cancer or it isn't. We can see them. Yeah, you'd rather not do it, but we don't know. Some think you might, some think you don't might. Let's do something definitive here. We see the lesions. Let's find out what those lesions are. God forbid they might be bladder cancer. I've seen
prostate.
that.
In the prostate?
Yes, sir. In the prostate, urothelial, lower tract urothelial. I don't want to scare you, but yes, it could be. You could have lower tract urothelial lesions in there. So, let's go do something that is definitive.
Rick, who else do we have? I wasn't aware we had two more.
Well, but, Phil DePaola came on late and asked if he could have some time, and Matt Krieger said he wanted to put his question in the window, which he did, but it's really too long. So let's hear what Matt's question is, and then we can go to Phil. I will say for everybody, and we put it in our reminders every week. If you need time and you want to be sure you get time, please be here in the first 10 minutes. We just have too many people just to take people ad hoc in this group. It works in the active surveillance group and it works in the lower intermediate because they have fewer people. But we're always pushed up against the wire. Matt Krieger.
Hi, I appreciate that. My question is really not urgent. If Phil wants to go, I'm totally fine with that because I can put
go
my
ahead with your question, Matt. Take the time when
okay.
we offer it to you, man.
Okay. Yeah, thanks. So I described it in the chat a little bit there. So I get a Kaiser, and the level of the PSA testing has always been 0.06 or less is undetectable. And it's always been fine. I've never minded that. But a lot of people have more specific testing, and I'm just wondering in my situation whether it makes sense to push Kaiser to have a more sensitive test. Does it add value to me to know what's going on under 0.06 in my situation? I'll describe the situation more if that would be helpful.
Just remind us, did you have a radical prostatectomy?
No, I did, so Gleason 5+3, and I did radiation. I did EBRT and high dose rate brachytherapy 3 years ago.
Okay, so
And then I did,
I'll
yep.
stop you right there. If it were me, I wouldn't look for a more sensitive test because you still have a prostate. And frankly, I did low dose brachy, IMRT, 2.5 years, and the test that I got was to 0.1 because there's nothing that you can, even if it's less than that, there's nothing you can do. So the simple answer for me, from the way I see it and what I did, 0.06 is just fine. Len, you want to comment on that?
Totally agree, Rick. Totally agree with you. No point in, there's no actionable information coming from
Okay.
PSA that's less than 0.06.
Okay, that's great. Wow, a simple answer for once. That's amazing. I'll take it when I can get it. Thank you very much. Appreciate it.
We try
Doesn't
to
happen
tell
often.
the guys here, you really don't need oversensitive PSA tests. And if you are looking for them, it only really makes sense if you had a radical prostatectomy. If you
Yeah. Okay.
didn't, getting it to 2 decimal places or even 1 decimal place is probably going to do you just fine because you're staying on top of it that way. Are they testing your testosterone each month as well?
They don't, but I actually go outside to get it because based on advice I heard here. So I've gotten a testosterone test the
Oh,
last 3 months, I think, so I
oh
can
wow. I
keep
mean,
a loose tabs on where it is. Yeah.
Kaiser should do it. Kaiser's usually
Yeah, it's
big.
weird,
It
isn't
should
it?
be.
Yeah.
Kaiser tested my testosterone monthly. Jim Marshall, quickly.
Yes, indeed, Ellie. I get it essentially every month. All I did happened to be to then ask for it, and they, no problem.
Thanks, Jim. So there you
Okay,
go.
I'll
We're
take that
saved.
back. I appreciate it. I did ask once and I didn't get it. Yep.
Then ask them for it. Tell them you want it.
All right,
It's
thanks.
usually, the reason they give it is because they used to. I don't know if they still do. They used to dole out. Are you still on an LHRH or not, Matt? I don't have your numbers in front of me.
Sorry, LHRH. It's been a while. I can't remember what that is.
Lupron, or are you still on Lupron or Firmagon or something like that?
No, thanks. No, I'm not on those anymore at this point.
Okay. So because they used to dole out those drugs based on the level of your testosterone, so they were very eager to test you monthly. But if you're not on those, it's also good for you every 3 months just to get it to see how you're recovering.
Okay, thanks
Okay.
much. Appreciate it.
I'm with Kaiser and have never gotten more than 1 decimal point in my results. You're getting 2 decimal points. You must be in an ultrasensitive test somewhat because I have never seen anything less than if I get below 0.1, I'm undetectable. They never give me 2 decimal points. So
Okay,
you're definitely doing a lot better
guys.
than any of the tests I've seen.
All right. So we got hands, and we want to get to Phil, and it's right at 8 o'clock. So can we leave with respect, Jim? Can we leave this one because I
Yeah.
think we've sort of Matt's happy, and we've like
Oh, right.
about hit it into the
No,
grave.
no.
Guys,
Right.
stick around because Phil has a difficult case, and we don't see him that often. And he did come in a little late, asked for time right away. So let's listen to his story and see if we can help him.
Thank you for hanging in. I just got off 13 years of prostate cancer. Gone through many treatments. Started chemotherapy in May, I guess, of this year. Went through 7 doses of chemotherapy. My cancer is particularly in my lungs and some lymph nodes nearby, mediastinum, if that helps. The 7 doses of docetaxel had very little impact on my cancer. The some of it stayed the same. Just a few of the lesions shrunk a little bit, and then I got 1 additional lesion. So it's a toss-up as to how effective it was. My doctors don't, and my PSA went up slightly during the time, not very much. And so I see 2 doctors, 2 oncologists. Both of their recommendations were to go on lutetium-177, Pluvicto, and I'm going to start in early December. Any insights you can share with me about the impacts I could expect from Pluvicto, and whether anybody thinks that not anybody, but whether there's a strong feeling that I should have continued on beyond 7 doses of docetaxel.
So there's a couple of things. First of all, I think Al Latimer, are you still here, man? I don't see you anymore. I think you might have left. Al Latimer's the guy.
No, I'm still here, Rick.
Oh, you are there. There you are. Okay, so we'll come to you in a second because you hit you got the bingo because you got the expert on here, and there are other guys. I'm not sure if they're on right now that have done it, but we've got loads of guys. Secondly, have you done PSMA tests, and do we know you are PSMA avid?
Some of my lesions are avid, some are just mildly indication of PSMA. I've had both PSMA scans and FDG scans, so they see the cancer in different ways, I guess.
So no, that's really important. So we know before you go in that a good not a good, but some percentage of your lesions are not PSMA avid and are not likely to respond to the lutetium. Is that right?
I guess what's right is I've heard even sometimes ones that don't show PSMA avidity are affected by the treatment in a positive way, but the ones that are very avid should respond.
I'm not sure where you've seen that, but if you can show us that the non-avid PSMA lesions respond to treatment, we'd be very interested to hear it, to read it, to see it. We've seen too many guys in this group who have been through lutetium, and their avid lesions have responded, and their non-avid lesions have not, and they've lost time in treating those non-avid lesions. So who are your doctors?
Tanya Dorff and Matthew Reddick.
Okay, 2 very good doctors. But I know that Tanya Dorff is not very big on these people who are. She doesn't focus much on concordance. Reddick, I don't know. But if it were me, before I started the PSMA treatment, I'd say to them, well, what are we going to do for the non-concordant lesions? Because you don't have the time to go through 6 sessions of lutetium and then worry about all those lesions that didn't respond. And I don't want to call out the men that died this year who took that track. What we really, really need to know, and both of these are really good doctors, are they doing any tests to determine if the lesions that are not PSMA avid have peculiar characteristics?
Let me just say what the plan is, and then you can consider it. The plan is 2 doses of lutetium and then a PSMA scan, and we can see what's happening or isn't happening.
Okay, okay,
That's
that
the plan.
makes sense.
They also said
Okay.
lutetium has less side effects than cabazitaxel, which would be probably the next step. And
Yeah, but it's not the cabazitaxel that we got to focus on. We've got to find out earlier. And Len, I really want you to come in on this one, especially with the BXCL701. We've got to find out as early as we can if you have disease that is looking like small cell neuroendocrine, because the window to treat that small cell neuroendocrine is short. And there are treatments available. And if we piss around with the lutetium, we may miss that window. So to say, well, let's see what happens, and then we can test it later, to do it sequentially. For me, personally, I'm not a doc, but for me and from what I've seen, I would not do that. I would insist on them trying to identify what those weird lesions are that aren't expressing much PSMA, because it's most likely that those are the lesions that are going to kill you, not the ones who are expressing PSMA. And that's what I would say to Tanya Dorff, and that's what I would say to Matt Reddick. But you have to be your own best advocate, because they're going to say, well, you know what? Let's just go through. Let's go through a couple. Let's see what responds, and then we'll worry about what to do next. No, we know you've got a bunch that aren't going to respond.
well, I've had a third of my lung taken out, so I've had upper left lobe removed. I've had 3 biopsies in various nodules. They've tested them for small cell, and I'm not sure if it's neuroendocrine or small cell, but they've done some additional testing on the tissue and said it shows it's negative. And so I don't know what more they can do at this point in time other than try to resample. My chest is a little bit of a pincushion right now, but
Okay.
they can
Did
resample.
they send, I'm sure they did, knowing who the doctors are, did they send the sample of those lesions? Were the lesions they removed, do we know if those were avid for PSMA or not?
I don't remember. I'm sorry. The last
Okay.
one was probably
Here's
about
what
4 months ago.
here's what I would be asking the doctors, because you don't want to have to go through more interventional treatment if you don't have to. What we want to know is, what do those lesions that are not responding to PSMA right now that we know are there, what do they look like? What do we know about those lesions? If they can tell you they know everything about them based on what they already took out, fine. Then let's talk again. If they don't know, if it were me, I'd be pushing to drill down on those lesions, and you can do it at the same time. You start it before you start your lutetium, and then drill down. To be honest, to speak about how the lutetium is going to affect you if you're only doing 2 sessions, Al's not going to be able to tell you much, because he sailed through his first treatment sessions of 6 at a time. And then most recently he had a problem, but he's done so much that just doing 2 sessions, we see loads of guys. I can tell you 2 sessions, you may not even notice it. You might not notice it at all after the first one, and maybe you might notice something after the second one. But that's not where your focus should be. The focus should be, where are these nasty? What are these nasties, and how can we treat these nasties? Okay, I said way too much, Len, because I'm
Yeah,
passionate about this neuroendocrine stuff.
Yes.
right.
Go ahead.
And one thing we have to keep in mind is this is not black and white. Uh, your cancer can have some neuroendocrine cancer and other, even within the same lesion, you can have some that are neuroendocrine, some that are not. So the
Right.
fact that they looked at your lung tissue and said, nope, no neuroendocrine here, doesn't necessarily mean that it isn't elsewhere. You could, Rick, couldn't they do a liquid biopsy for the biomarkers for a neuroendocrine? There are at least 3 or 4 biomarkers. Um, that way they can pick it up
Yeah.
wherever, you know.
I mean, I'd be pushing them every which way, and they know it. I mean, Dorf is good on this stuff.
Yeah.
She's good on the neuroendocrine stuff, and I'd be pushing her every which way to say, I want to know what the neuroendocrine, if there are any sign of any neuroendocrine markers. With Herb, God rest his soul, we made a mistake. We figured if the neuroendocrine isn't in one spot, it ain't in any of the spots, and we were wrong. Neuroendocrine can show up anywhere. It's not like other prostate cancer. Most other prostate cancer, the lesions are very typical all across the body wherever the metastasis is. But the neuroendocrine doesn't follow that. And what we want to know is, are any of those, and it isn't really neuroendocrine. I say neuroendocrine because the treatment similar is really this small cell disease.
Mm-hmm.
Even if we biopsied them and looked at them under a microscope, what can we see? Because if they are, we shouldn't be talking cabazitaxel. We should be talking carboplatin or another platin. And what we do know, what I've learned from Dr. Munster, God bless her, who's on our advisory board, is that the window to treat neuroendocrine is short, and that you've got to move quickly, and that if you do, you can nail it.
Okay.
So,
One other thing, I did take a blood draw the other day, and we're sending it back for a full assessment of, I guess, the genome to see if we see anything that might have changed from a previous test I've had. So I don't know if you can actually tell in those tests whether you have neuroendocrine or small cell, but is that a possibility that you
I
can
don't know,
tell?
Len, is there something that's going to show up in those tests? Can we see markers in those tests? I'm just not sure.
I couldn't hear what he said. What type of test was it?
They drew some blood for a liquid biopsy.
Well, yeah, sure. That could they could pick up the neuroendocrine markers from a liquid biopsy.
So we've taken
If they're
that.
looking,
So,
if
so
they're
you did
looking
that
for
if they're looking for it, yeah, I suppose.
what you've got to do is you've got to check. You got to check with what's his name, Matt? What's his name in at UCLA and Tanya Dorf, and ask them. I trust you're looking for the neuroendocrine small cell markers. You got to tell them specifically. I want you to be sure. Are you looking for these? Because they may do a sequencing but yeah, they can be looking. They should be looking for them. And like I say, if it were me, and if I had nodules that could be seen that were not avid, PSMA avid, and I could stick a needle in them, I would do that and find out if those are neuroendocrine. Have somebody look at them under a microscope, because if you've got one neuroendocrine lesion in there, forget the don't forget the cabazitaxel, but you add a platin to the cabazitaxel. Again, I don't want to give medical advice.
Sure.
But that's what we've seen them do if they know. The problem is they spot this damn evil neuroendocrine small cell disease, they always spot it too late. And now there are drugs that are in development that Len wrote about in our reminder this week. Look in our reminder this week. And I wrote about this same drug a month ago. And there are trials going on where maybe you can add A to B and maybe it'll make things different. And they're focused on neuroendocrine. It's all too often with guys who have advanced disease and you have weird disease. It's 5+4. You don't express PSA. This is weird disease that usually turns into, not usually, but can turn into small cell.
I'm
And
not. I'm 3+4. Sorry,
oh, you were 3+4.
3+4.
Okay.
Yeah,
Okay. But
not that makes
even
that much difference, but I wanted to clarify.
and you tell them if they're not sure, exactly what's going on, tell them to give Rahul Agarwal a call. They both know him up at UCSF and talk to Rahul about, is there anything that you could be doing with him? But we think from what you're telling us, it sounds like you've got this weird disease. And messing around with the Pluvicto may be fine in the short run, but even now, whilst you're doing the Pluvicto, let's be looking for the solution for this strange disease. Let's try and biopsy it. Let's think what we could do now, not 6 or 8 weeks from now.
Right. Well, we're doing the blood right now. Like I said, I've had 3 different biopsies in and around my lungs, plus the lobectomy. So we've got 4 specimens within the last year. So we know we have the tissue. Then maybe they just have to go back and retest it.
No, because the disease changes all the time and it changes quickly. So what you might see from a year ago, it might not be the same as what you've got today. And again, Dr. Dorf knows that well.
Okay.
It's dynamic. It's really dynamic. And as the cancer advances, it gets more and more dynamic.
I'll
And
be
so
talking
that's
about it next
why
week.
I keep saying, if we know that there's a weird lesion and we can see where it is from the PSMA scans and what have you, can we get at that lesion? We may not be able to get at it, but can we get at it? Is there a way to look at it under a microscope? Does it look like it's small cell? And if it does, can we add platinum to a mix? You probably don't want to do it at the same time as the lutetium because your blood counts won't tolerate it, your marrow won't tolerate it. But if it were me, that's where I'd be focused. I don't know, Len. Sorry,
Yeah,
I'm
I mean,
sorry
we could be getting ahead of ourselves with
Yeah,
with the small
yeah,
cell and the BioXcel compound because we don't know for sure that he has neuroendocrine or
right,
small cell. So
right.
however, I did put the name of the compound that's in clinical trials, Phil, in the chat.
Chad?
It's BXCL 701. The BXCL is uh, the name that BioXcel uses for their compounds in development. And they used it with pembrolizumab, which is a checkpoint inhibitor, and
Right.
they got some pretty good results in phase 2 trials, turning cold tumors like we have in prostate cancer into hot tumors that the immunotherapy can treat successfully. But again,
CL701. Okay, I'll look that
yeah,
up for sure.
Okay,
And
look, to save yourself some time, read what Len wrote in the reminder for this week and read what I wrote in the reminder for the October 24th meeting. And that would be a good starting point before you start do your own research by all means, but it will be a good starting point. But as Len says, we're getting ahead of ourselves. What we really want to know is that what you've got? And if you have, even before you got to BXCL 701, you would probably be looking at a platinum.
So that's a carboplatin or cisplatin, is that it?
Well, a platinum based, they usually use carboplatin, but it doesn't have to be carboplatin. It can be not cisplatin. What's the other one that they do use other than the carboplatin? Len,
I think it is cisplatin, but
Is it? Oh,
cisplatin is a tougher one to tolerate than the carboplatin. Carboplatin's
okay,
easier.
okay,
okay. Well, thanks for the insight. I appreciate you hanging in for me.
okay. Let us know, but
Yeah.
you're a good advocate for yourself. Drill down on these issues. Push them really hard on these issues. This is where you want to go. You know.
Yes, I'll do that for sure. And I'll go back and check the tests that have been done on the biopsies I've had. The last biopsy was about 4 months ago, and that's the one where they tested, and it appeared not to have those small cell or um, neuroendocrine. But again, I have other samples that they might want to check also. Maybe they didn't do
Well,
the homework.
just we said to you, with neuroendocrine, it can be in one place and it won't be in another. It's not like
Yeah,
the adenocarcinoma. If it shows up like this is what it is in most places, which we seem to think is the case. With the neuroendocrine, it's not. And so specifically, that's why I'm saying we should be testing samples that did not express PSMA. Did they test samples last time that did not express PSMA?
that I can check pretty easily.
All right, guys.
Thank you. Appreciate your time.
All right. Happy Thanksgiving to everybody. Thanks for hanging
Yeah.
in there. So all this time, and good night.
All right.
Right.
We'll
Yes,
see you
everybody.
next week.
Okay,
Stay
bye.
safe.
Gobble
Right.
gobble.
Thanks, Glenn.
Gobble,
Good night,
gobble,
everybody.
gobble. Good night, everyone. Good night. Good night.
Good night, all.